So I can do this.
Okay, Whit, do you see Dr. Birch and me?
Yes, I see the presentation
Okay.
and I see you.
Okay, there you go. All right, you good to go?
Just messing. I'm just messing. I'm good to go.
All right.
All right, everybody. Okay, we're going to talk about some encephalitis. Clearly, this is a very broad topic, and that, and y'all know, I'm just going to put it out there. I hate encephalitis. I really do. Give me some bacteria, please. Something that I can actually diagnose. As you will see in life, in your experiences, and then also in this lecture, a lot of times you do a bunch of whole huge workup and do not find out why somebody has encephalitis. And it's just so not fun to tell parents that, for sure. So just some quick definitions. Meningitis, y'all should know, inflammation of the membranes of the brain or spinal cord. And encephalitis means acute infection with focal or diffuse inflammation of brain parenchyma. Now, obviously, it says infection there. There are some kind of encephalitises that aren't necessarily acutely associated with infection. This can be associated with viral, bacterial, fungal, protozoan, and also autoimmune processes. And it usually is a result of an unusual complication of a common systemic infection. But the hallmark here is that there has to be presence or absence of normal brain function, and that's the most important distinguishing feature between encephalitis and meningitis, okay? And so you can have a continuum between the two, and that be meningoencephalitis. But with encephalitis, you need to have some kind of change in mental status. And so there is a case definition that was produced sometime around 2013 by the International Encephalitis Consortium. And I actually like how this works to kind of tell you whether or not somebody has encephalitis versus encephalopathy. So essentially, it was created to simplify the consensus of the diagnostic criteria for a standardized case definition. Young infants are more likely to have infectious encephalitis without a pleocytosis. So this is really important because this means that you don't have to have a CSF pleocytosis to make the diagnosis of encephalitis. And so that's something commonly that I will see where people will think that it's not encephalitis because the CSF is normal. But that doesn't mean anything. You can definitely have encephalitis with a normal CSF. So just remember that. And so on the left-hand side, you see encephalopathy type criteria. On the right, you see brain parenchyma and inflammation criteria. And in the middle, when they both go overlap each other, is where you get your actual case definition, okay? So you need one major, which is encephalopathy, right? So altered mental status, and then at least two minor to make it possible, or three to make it probable. Okay, and so of those minor criteria, they can come from the left side or the right side. So that could be an abnormal EEG, it could be seizures, it could have focal neurologic findings, or on the other side, it could be fever, CSF pleocytosis, or neuroimaging consistent with brain inflammation. So it's just a combination of those minor criteria that would make the diagnosis. Because the other thing is too, it's very common, or in my experience, that you actually have encephalitis and you have a normal MRI too, right? So it's just one of those things that it's not always 100% that you're going to have abnormal CSF or MRIs. So encephalitis occurs about 7.3 cases per 100,000 person years in the US during 2000 to 2010. Now, clearly we're all the way up to 2020, but encephalitis, at least from an epidemiology standpoint, is not always looked at pretty frequently. So this is kind of the best that we have. If it's less than a year, it has the highest incidence when you're looking at kids, and that's 13.5 per 100,000. And then the lowest incidence is children age range 10 to 14, and that's 4.1 per 100,000. Obviously, we all know that there's seasonal increases, right? So in the summer and fall, you have more outdoor activities that increase your chance of arboviruses, tick-borne diseases, those kind of things. In addition to that, that's our big enterovirus season as well, right? And that's a big player in encephalitis. So there are quite a bit of ways that the brain can get infected and cause encephalitis. There's two main forms of encephalitis. The first one is primary infectious encephalitis, and this is essentially where you have direct invasion of the CNS by a pathogen. And then the second way is immune-mediated encephalitis. And so that is why Dr. Dingle is here, and she's going to talk about it a little bit later. And then as far as a primary infectious encephalitis, there's several ways that this can occur, and you can see them all listed here, but organisms can invade the CNS via viremia, subsequently crossing over the blood-brain barrier. So we know this is also how meningitis happens, typically with virus or with bacteria. But arboviruses is a big way that this happens. You can get retrograde axonal transport, that's rabies. So you remember that goes, rabies is incorporated into the peripheral nerves, right? And it goes up the peripheral nerves until it gets to the central nervous system. Once rabies gets to the central nervous system, you're screwed, basically. There's nothing that you can do for the person. But you can prophylaxis the person in between getting rabies inoculation all the way up to the point where it gets to the central nervous system. You can infect neurons leading to cytotoxicity, and that's HSV is the big way for that. Pathogens can cause inflammation leading to tissue damage. West Nile virus is always also part of that. And then you can also have HSV kind of in that as well. Pathogens can cause vasculitis leading to tissue ischemia, that's VZV, which is chickenpox. Or varicella. Some organisms or vaccines can trigger the CNS autoimmunity, so that is Dr. Dingle's area. And then you can have direct CNS viral infection and triggering of immune-mediated disease that can coexist together. So you can have combinations of all of this. So this is where I was talking about as far as the etiologies go. Etiology is identified in roughly 50% of cases of encephalitis in children. That's half the cases. And in my experience, and Dr. Widener, you can echo this, it is more like less than 10% of the cases, honestly. And if you are going to identify an organism, most of the time it's going to be HSV. But it is a lot, you spend a lot of money for not a lot of return. Of the unexplained cases of encephalitis, more than 60% lack an identifiable cause, even with comprehensive research testing, including advanced molecular diagnostic technologies. So basically what that means is all those expensive PCR panels that we order, titers that we do, etc., the workup is very expensive and the yield is very, very low. Okay. This is not for me to go through and name every organism that can cause encephalitis, okay? This is a very nice chart, or not chart, but a table for y'all to have. It's from Up to Date. And you know, I don't hate Up to Date for places to go to look for general information. And this is a nice summary of all the organisms that can cause encephalitis. It is important for you to bring this up when you're working a kid up for encephalitis, because if you see it in front of you, you're going to remember what questions to ask, right? And so that's helpful and can direct your questioning, because part of this workup is an aggressive history and trying to figure out what exposures that the kid has, okay? So it's a whole bunch of different things. The red, the organisms in the red are things that you can treat, okay? So you can see on the viral side, the majority of them, or a whole bunch of them, you can't do anything with. And even the ones that are in red on the viral part, like CMV or HHV6, if you wouldn't do any kind of treatment with those in a normal immunohost, it's usually immunocompromised patient that you would do something with that, okay? And then everything on the right is either bacterial, fungal, or parasite. So this is also a nice little chart that I actually got from this great review article in Infectious Disease of Clinical North America that kind of puts together certain risk categories and particular viruses and bacteria that you would think about. So for instance, if you know, oh my gosh, this patient has encephalitis and mom says they live in a rat infested, trailer. Well, then you need to be thinking about LCMV, right? But if you go over here and it comes over here and it says rodent, what do you see? LCMV. So it's nice that it has, certain organisms that you can think of. If they went traveling, right, and they went to the Caribbean, well, this is where you start getting the dengue, chikungunya, Zika, all those kind of things, right? If they are eating unpasteurized dairy, you should always think listeria, 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 number one, but then there's also other things that can be associated with that too. So this is where you just have to make sure that you get a good history. Okay, in the neonatal period, it's very hard to get a really good clinical presentation of your traditional altered mental status. Things could be that you might see as fever, poor feeding, irritability, lethargy, and sepsis. So what else does that mimic? It can mimic meningitis, it can mimic sepsis, it can mimic all sorts of things. But the biggest thing that you don't want to miss in the neonatal period is HSV. All right, that's the big one, and it's the highest that should be on your differential. And so in those kids, you could have apnea, seizures, paralysis, coma, all those kind of things. The mean time for this for appearance is approximately 11 days to 2 weeks after birth. Okay, that's typically when you're going to see HSV, meningitis/encephalitis, all right? And then these kids, you can't tell the difference between meningitis and encephalitis, so we treat it like it is encephalitis, okay? Because actually, in an older kid and adults, you can totally have HSV meningitis and not treat at all, right? It's technically aseptic meningitis. And so, but in smaller kids, we definitely treat like it is. Do it. It's scary. Actually, Becca tells me that, Dr. Widener is like, it's a, so-and-so, really, it's just meningitis. We don't have to treat with acyclovir. And I'm like, we're going to treat with acyclovir. I get really nervous about it. But and encephalitis, you absolutely have to. This is meningitis that we're talking about. And the adults with meningitis, they don't always treat. Anywho, so basically, we all know these things, but it's nice to remember. Your greatest risk to the infant is when mom has primary outbreak at time of delivery. Why is that? It's because mom does not have antibodies made to the HSV, right? And so because there's no antibodies there, none of those antibodies have crossed over the placenta to protect the baby. So the baby is at greatest risk also for infection. HSV2 is you have a higher chance of having worse outcomes and bigger disease versus HSV1, although HSV1 absolutely can cause encephalitis as well. And so you want to just kind of remember the risk of transmission from mom to baby is about 30 to 50% with maternal primary infection. And that includes if the child is delivered with a C-section. Okay, so that makes no difference whatsoever in how you treat an infant who is born to a mom with the active lesion. So the Red Book is a fantastic place to go look up how you deal with an infant born to a mom with an active lesion, okay? If it's primary herpes and the child looks fine, you actually treat with acyclovir for 10 days. So a lot of people don't realize that, so you really need to make sure that you have that Red Book with you. And y'all know one of my biggest pet peeves. Anybody third years know? I know Alyssa does. She said, which pet peeve, Dr. Birch? Because you have so many. make sure that you have the most up-to-date red book and that you're looking at the most up-to-date red book. Make sure you're getting the right recommendations, okay, because they do change. I'm busted before on that. So anywho. And then just look at the difference between risk of transmission from mom to baby and recurrent infection. It's less than 3%. So we still will go through and kind of look with moms with active lesions, do testing, those kind of things, but you don't always start acyclovir. All right, so older children, their clinical manifestations are what you would traditionally think of as encephalitis. Initially, they can be subtle and also diverse, but typically you think of headaches, stiff neck, photophobia, fever, vomiting, irritability, definitely change and altered mental status. And that is the hallmark of disease, is that you have that alteration of mental status. So here is where I like to talk about my detailed history and also doing a good physical exam, okay? So this is just in general. If you have all of these kind of questions in your head, or keep this slide, this will help you in life with a whole bunch of different infectious disease stuff. And when you take my rotation, then I'm going to ask you all of these things too, a lot of times. So pets include cats, dogs, reptiles. Don't forget the reptiles, and please don't forget the gerbils and hamsters. Chinchillas also count as rodents, okay? And those are common things that kids have growing up, right? So I had a hamster growing up. I could have gotten LCMV from that, okay? So don't forget. Travel and activities. So international travel. If they were during warm climates, remember in the South, you absolutely can have tick-borne diseases throughout the entire year, especially from Louisiana, because it doesn't get cold enough. No, but really, so you have to know what's been going on. If there has not been a deep freeze yet, which is right now, y'all, we're almost in Thanksgiving, and we barely had one even little frost. So it definitely needs to be on your differential for tick-borne disease, mosquito-borne diseases, those kind of things. You want to make sure that you're asking about outdoor activities. That includes freshwater sports, right? So Naegleria fowleri, I've had one in my career, was here from South Carolina, whether or not they hunt, okay? So you have to really know also what kind of things they're hunting. If it was their first kill, I know you've heard me say this before, but if it's their first kill, right, you either get painted with blood or you drink the blood. And you need to know about that because your eyes are mucous membranes, your mouth is mucous membranes. So if you're painted with blood and blood got in your eye, you can get Rocky Mountain spotted fever that way. You can get toxoplasmosis that way. You can get a lot of different things that way. It's important that you ask those questions. Are they hunting feral pigs? Feral hogs, that's really big around here, right? So they carry brucellosis pretty bigly. Ooh, how'd you like that? Woo, sorry. They definitely, that was not supposed to be funny. They carry brucellosis quite a bit, right? So you need to know, are they around horses, right? Have there been any kind of cow abortions? Not abort, but aborted calves. I mean, I know this is really weird and it kind of sounds funny, but it's really important because you worry about Q fever, you worry about brucellosis in that. And that absolutely can cause encephalitis. And then animal exposure, rats, mice, farm animals, deer, feral hogs, bats. Don't forget to ask, is their house infested with bats? Do they have guano? Have they found anything? Do they have stains on their ceilings? Because I've found that before too, and it's guano poop. And oh, by the way, they had bats infestation. Actually, our last rabies case in South Carolina was that exact situation where a woman lived in a bat infested house and she ended up dying from rabies. So you have to ask the questions. And then foods, unpasteurized milk products, fancy cheeses. I always say, do you go anywhere and get the fancy cheeses from France or Italy or somewhere around there? Because a lot of those cheeses from European countries are unpasteurized, and you might not know. And then imported queso. So like if you have someone who family members came and brought queso with them, that probably is unpasteurized, actually. Undercooked meats, unwashed vegetables, seafood, all of those kind of things. And then of course your vaccine history, and don't forget the sexual history because HIV can give you encephalitis as well. Isn't that right, Dr. Widener? And then also syphilis can too. Okay, so this also is teeny tiny, but this is also an up-to-date, and I just like this because it also gives you a nice little historical clues that you can look at, especially with having to look at certain rashes, if there's vesicles there or not. That might lead you to look at certain organisms more than others, okay? If they've been swimming, if they've been spelunking, if they have been having sexual activity, all those kind of things. And then also, this is in there as well, if they've been to particular places on travel, okay? So that's where you get your Japanese encephalitis. You can have Murray Valley encephalitis, hantavirus, like all sorts of different kind of stuff. West Nile is big. Malaria will cause encephalitis as well, so you have to remember that. And a quick little workup. So I tried to put everything on the left-hand slide, things that I would probably do in every person. And then on the right is different serum workups based upon history. Okay, when you're working someone up for encephalitis, there's 3 places, 3 sources where you get testing from, all right? The first one is serum, the second one is CSF, and the third I put in other category, all right? And so those are like, and we'll kind of go over those, but like respiratory viral panels, stool viral cultures, stuff like that, okay? So you always get a CBC and a CMP on these patients. CMP, you're looking for increased LFTs. That might give you a hint that maybe we're dealing with an acute viral infection. EBV and CMV titers are always helpful because they are definitely up on the list. Don't forget with EBV, what do you have to also order? EBNA. Please don't forget to order the EBNA, all right? And the reason why I say this is because it comes back a day later, sometimes say 2 days later. And so if you forget to order the EBNA, that just pushes it back multiple days before we would get that answer of could this be EBV or not, okay? CMV, Dr. Widener cringes when I put up here IgM because you can have a false positive. It's actually a high chance of a false positive, but I think I just put that up there anyway because you're not going to do anything with CMV, and if it's a false positive, but it gives me a name of something, that makes me happy. So good. HHV6, I'm just messing. HHV6, I put on here, and the big reason why I put on here is because on the BioFire meningoencephalitis panel, they do have HHV6 on that as well, so it can be helpful to look at the serum. And then obviously blood culture if you suspect a bacterial etiology as well. And then others based on history, and there's a whole list of them. HSV PCR, West Nile virus, IgM and IgG, HIV, ELISA, and you can potentially do viral load on that. Treponema antibody and RPR. If they're unvaccinated, then you have to go through all of those vaccine preventable diseases and do titers based upon those. Travel association, you know, dengue, chikungunya, Zika titers, malaria, thin and thick smears, TB, quantiferin gold, PPDs, all that kind of stuff. Born, you know, Rocky Mountain spotted fever, ehrlichiosis, all that kind of stuff that you would actually do. And remember, that's the importance of why you get the CBC and the CMP and other things as well, right? Because you can have changes on those that might push you more one way versus the other. And then of course, unpasteurized milk, you have listeria, you get those from culture. Q fever, brucella, and toxoplasmosis are serology, okay? And you know, that's the same thing as titers. For the CSF, which is the second place that you get your source of your testing from. White blood cell count with differential, of course, glucose, protein, red blood cell, that's what we would normally do in any time, most of the time you get CSF. Bacterial culture, and then here's the meningoencephalitis panel. And then remember, and I'll show you what is on that meningoencephalitis panel, but EBV is not on that meningoencephalitis panel, at least the BioFire. Now, you need to know wherever you go practice what PCR panel you have available to order and what is on it, all right? So you know if you're catching the certain viruses to test or not test on that panel. Here, EBV is not on our BioFire meningoencephalitis panel, so you have to add. And sometimes they can get you serology, sometimes it's PCR. That's something you're going to have to ask Send Out Labs what is available for you to order. Okay, and then AFB culture and PCR, if this is based on history, so TB, PCR, CSF, VDRL, West Nile virus serology actually on the CSF, wet prep for amoeba if you feel that Bagliaria fowleri could be there, or other additional studies that might be available. Okay, here's BioFire meningoencephalitis panel. It's actually decently sensitive and specific, but if you look, bacteria is not going to be helpful for this except for Listeria. It does pick up Listeria. But then you have all of these viruses. So CMV, enterovirus, HSV1, HSV2, HHV6, human virus, which is can be a cause definitely of encephalitis, and then VZV. So EBV is not there. And then Cryptococcus as well as on that. And other workups, so it is helpful to get an RVP. And again, you're looking specifically for influenza if it's during the season, adenovirus, and then enterovirus, so the rhino enterovirus here. Also, it has mycoplasma on it, which is helpful because we all know mycoplasma can cause encephalitis. Because remember, that's one of those things. TB and mycoplasma can almost do any kind of thing. It can show in any presentation you can think of. So always go with those two if I ask you etiologies. And then other areas based on history. So if you have vesicles, you might consider HSV or VZV. You could get stool PCRs if there's diarrhea. You would do a rabies PCR on the nape of the neck if you're worried about rabies, or a brain biopsy. So you could do all sorts of stuff. So I gave you some tidbits here. Eosinophilia in the CSF. You should be thinking weird stuff, funguses, parasites, TB, okay? If you have an EEG with PLEDS or temporal lobe localizing EEG activity, you should be thinking HSV, right? And these are just kind of helpful for tests. It doesn't always happen like this, but if you see this, it should be a trigger in your mind of things to look for, because it could also be TB and VZV on that as well. But where they're going for on the test is HSV for sure. Ring enhancing lesions, toxoplasmosis, ding, ding, ding. You can also see it with amoebas, fungi, or TB as well. Thalamic and basal ganglia lesions, you want to think respiratory viral viruses like influenza. So usually that's the big one with the flu. Rhomboencephalitis, listeria, 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 and then other things like mycobacteria and enterovirus, A71. Cerebellitis, typically is going to be VZV. And the presence of myelitis with encephalitis on imaging, you're going to think enterovirus and West Nile virus. Okay, so those are just key words. So treatment really quickly is just supportive care for most of these. There is individual certain organisms that you obviously can treat, but really you want to protect the airway, especially if the person is severely altered. You're going to manage intracranial pressure. You're going to do fluid and electrolyte management and seizure control. And thank you goodness, thank you Jesus, ID does not do any of those. That would be for y'all to do. And then when it's difficult to differentiate between bacterial versus viral etiology, it would be appropriate to start antibiotics, okay, until you get those cultures back, your 36-hour rule out. Remember, 36 is the new 48, right? And then empiric IV acyclovir. So this is really dependent upon the provider, okay? I don't always start acyclovir. If you ask ID physicians, half would probably say everyone should be started on acyclovir, maybe even more than that. Some would say no. Dr. Widener probably always would say start acyclovir. I'm kind of like, if I don't think HSV, I wouldn't necessarily start acyclovir. So it just is kind of one of those things. You're never going to go wrong in encephalitis if you start acyclovir, okay? Yeah, you need to swab everything. So you're already getting the CSF, and so you should be doing your meningo encephalitis panel, so you'll get HSV there, and then you would probably go ahead and get an HSV PCR in the blood if you're going to start acyclovir. Yeah, if it's an infant, right? If it's a 14-year-old, you're not going to do that. You're just going to swab the lesion. Well, yes, it's spinal fluid. Yeah, you're already gonna get that because of the meningo and stuff like that. Yeah. Sorry. Okay, and then this is just really quick. Y'all should know this, right? Treatment of mycoplasma is what? Azithromycin. That might or might not be helpful. We still do it anyway. Treatment of Bartonella is azithromycin, right? It may or may not be helpful. We just feel better if we do it. Treatment of syphilis is penicillin, those kind of things. You should know that, but those are just directed, true treatments if you have something. CMV I put up here. If you have a 2-year-old normal healthy child with CMV encephalitis, I'm not going to treat it with ganciclovir. But if I have a 14-year-old who is immunocompromised with CMV encephalitis, which we have had, actually he was 20, then I'm going to treat with ganciclovir, right? So it kind of just depends on the situation there. This also is from Up to Date. I'm not going to go through it all, but it's there for you to review. It has individual organisms and how you would treat it, right? So if you had Rocky Mountain spotted fever, what are you going to treat? Doxycycline, right? So it just kind of gives you those kind of things, and you can go through on your own leisure. Okay, ADEM. I will be real honest. This is not in my world. Treatment is not in my world. I don't even, Dr. Dingle, is it in your world as well? Dr. Dingle, is ADEM in your world? Okay. Mm-hmm. Typically, we don't really get involved with this either. I put it on here because it is part and it might be in your differential. So all of this information came from the Infectious Disease Clinical North America paper. And that's a nice review article, so it's in there. But basically, you're going to have some kind of prodromal illness typically. It's associated most of the time with some kind of upper respiratory viral infection, a couple of weeks prior to onset of the symptoms. And you're going to get MRI that's going to show multiple areas of lesions. And you can, half of them are going to have abnormal CSF. So that's not always helpful. And then we know first line of therapy is high dose IV corticosteroids. Second line might be IVIG and Plex. And I'm assuming that's really what we do. I'm kind of looking at y'all most of the time, usually. Mortality, though, is rare. So this is just an example of ADEM look like. I'm going to come back to this because Dr. Dingle is going to talk about that just really briefly. But just to finish in general with encephalitis, it actually has a pretty decent prognosis. So nearly all children with encephalitis in the US are hospitalized. It is a very expensive hospitalization. 40% of those most of the time require some kind of ICU level of treatment. Usually it's a very long duration of hospital stay and can be longer if they need rehab services in addition to that. And so the average cost is anywhere between $64,000 and several $100,000 as far as how much you would end up having to pay. Most children with encephalitis have incomplete recovery at discharge, but many of those fully recover, and they typically do within 6 to 12 months. So that's really important when you're talking to the families, is that they're not going to be perfect right away. This is going to be a long road ahead of you for your child and for the family to teach them how to do the things that they need to do. And so development of epilepsy is more common in those who presented initially with seizures. And if you do, that can be correlated with long-term neurologic sequelae. Children with abnormal neuroimaging are less likely to fully recover and report poorer quality of life at long-term follow-ups. There's an estimated 3% mortality rate of encephalitis in children. So as far as a mortality rate goes, that's pretty low compared to some other infections out there. HSV is the most common cause of pediatric deaths associated with encephalitis. But like I said, mortality is rare, and especially for other things like enterovirus encephalitis, which is probably one of the higher viruses that cause encephalitis or more frequently. Arboviruses have a low mortality, parenchyvirus, and autoantibody-mediated encephalitis as well. Okay, Dr. Dingle, I don't even know if you want to read about this. I just thought you might could give us some little tidbits about NMD. Yeah. Adeno, okay. Yeah, I mean, you have a good likelihood that it is going to be adenovirus. The problem, sometimes you get into it, is make sure that it's not right, because you can shed adenovirus for weeks. Same thing with enterovirus, and I think you see that quite a bit, right? Where you just have shedding over and over for a long period of time. But I would say that that's a pretty good chance that it is adenovirus, right? A pretty good chance if you got influenza on the RBC. Yeah. So I think by that time you have already probably most likely have made your decision to neurology and that kind of thing. I don't think that you necessarily have to, if your history's not there, to go into a tier 2 level workup if you have something like that. I think it's very reasonable. Mycoplasma is also one of those things. I see a lot of people ordering mycoplasma antibodies in a workup here. Please don't do that. It makes it very difficult for us to interpret, because mycoplasma IgM can stay positive for 6 months. And it might not be mycoplasma at all. So it makes it really difficult to look for.
Cool. Thank you for asking me a little bit about this.
That you're here.
I'll my mask off so you can see my face. And hello to those of you who haven't met yet. I hate that there's a pandemic and I don't get to come see y'all in person more, but I'm really excited to be here. I really enjoy taking care of patients with NMDA receptor encephalitis. It can be a challenging diagnosis to sort out, and we're often doing things in parallel with ID and neurology and sometimes even psychiatry. I will say one of the main kind of differentiating features in this is there's often a kind of more subacute presentation that involves psychiatric behavioral changes kind of leading up to when they get sicker. That's very often speech changes, so either mutism or word finding difficulties. But I've also had several patients who were admitted for acute psychiatric reasons, go to the psych hospital, and then get transferred back because now they've developed autonomic instability, more catatonia, kind of other concerning features later on. I think of it more in kind of teen age, but have certainly seen it present in younger kids, and even had a toddler that came in pretty acutely with kind of catatonia and seizures who ended up having it with a 3 or 4-year-old, which was certainly an atypical presentation that can happen. And the diagnostics, those are exactly the 3 things I wanted to point out. So usually you're going to have at least one of those be abnormal. So, I've occasionally gotten consults for new onset psychiatric symptoms with concern for autoimmune encephalitis. But if you have a normal MRI, normal CSF, and a normal EEG, the likelihood of it being a true autoimmune encephalitis is very, very low. So you don't have to have all three of those things be abnormal, but very often they are. This is the most common autoimmune encephalitis in children, but there are other rare ones. Usually, in most kids where there's concern for this, I'll say best to send the NMDA receptor from the CSF. CSF is much better than serum, but you can't send it from serum. I don't usually recommend the whole big long panel because most of those are just not seen in kids very often, unless it's something kind of out of the ordinary. We have other kind of concerns. And then, yeah, so treatment, I use steroids, IVIG. If there is autonomic instability, which is one of the later more severe findings, we'll put them in the ICU, consider plasma exchange. I give almost all of these kids rituximab. So the function of that being it targets your B cells, you're going to stop making the antibodies. So it's not a fast acting drug, but it's getting kind of to the root of the problem. The other thing you have to think about is ovarian teratomas, especially if it's a female teenage patient, really any patient will usually get abdominal imaging to look for any malignancy. In kids, it's actually more common to not have associated with malignancy. It's more common in adults, but I have seen that one time, and that's part of the treatment is getting rid of the teratoma, which is what's kind of triggering you to make the antibody. Yeah, so most of these kids do really well with treatment. I've even seen one of my very favorite patients. I have like a video of him on my phone because he's one of my favorites. As a teenage boy, football player, pretty good student, got admitted with like psychiatric symptoms, depression, just kind of acting weird, and then kind of quickly became truly catatonic. He had choreoathetoid movements, which is a really common feature. He had like choromotor changes, like was doing lots of lip smacking and just kind of funny things with his mouth, and was catatonic for weeks in the ICU. And by the time he finished treatment, he actually, the kind of fourth line treatment that I've only done twice is actually ECT for patients who have like true catatonia. He got ECT and is like going to college now. And it's been great. So,
Don't we have one patient with ECT?
yeah. So that's what we don't do that often, but I've seen it be like amazingly helpful when it does happen. So that's my short version.
Thank you so much.
Yeah,
I really appreciate it. Did I get it decently right on there? Oh, no, we'll be honest. I copied and pasted. That's really good.
A good resource is the kids hospital in Toronto has this. They're one of the main researchers in this, and they have what they call works protocols. If you're worried about autoimmune inflammatory diseases, that's one of the big place to look for treatment. So, and then so actually the guy who discovered this, Dr. Daniel, who's in Spain, is a super nice guy. And like you can email him and he'll email you.
Wow. My dog.
My visitor could be like, I'm just an email now. And he's like in Spain emailing me back.
That's awesome. Yeah, it's fun. Like once you get into fellowship and after like famous people in your world or whatever, they're not really they're normal nice people. Right. You know what I mean? It's kind of you're like, oh my gosh, you're so famous. Yeah. You're Sarah Long? Oh my gosh.
Yeah. The other name the and she always goes encephalitis. So when I really
you're like
encephalitis.
All right, y'all. Any other questions? Anything? Sorry, it's just kind of dry. Encephalitis is not very fun, but you got to think about these things and you will get questions asked about it. So y'all have a good rest of your afternoon. See you later. All right, I don't know what else I'm supposed to do over here. My husband gave it to me. I don't know. Yeah. I have no idea where he got it. He got it for me for a present one time. I know. And I've lost enough weight I can actually like get back